Chapter 31, PowerPoint Essentials. Radiation Control for Health and Safety Act of 1968. Consumer Patient Radiation Health and Safety Act of 1981. Safe Medical Devices Act, SMDA of 1990. Mammography Quality Standards Act, MQSA of 1992. The MQSA ensures that all mammography services meet minimum standards of quality and excellence. The SMDA and MQSA have had a significant effect on medical imaging. The 1996 HIPAA sets standards for electronic record security, electronic formats for record keeping, electronic identifiers and codes, and requirements for confidentiality and privacy rules. Medical devices are regulated by the Center for Devices and Radiological Health, CDRH, which is a branch of the FDA. The largest hospital accreditation agency is the Joint Commission on the Accreditation of Healthcare Organizations, the JCAHO. Its approval is linked to many medical activities, most importantly to reimbursement by the federal and state governments and many insurance companies. Accreditation agencies establish quality standards, assess them, and provide certification that individual institutions have met the agency's standards. Quality management consists of a coherent system designed to monitor equipment performance through a variety of quality assurance and quality control standards or benchmarks. Designed to monitor equipment performance and compliance with industry benchmarks. Two key components. Quality assurance. Quality control. Quality assurance is an evolutionary process that provides quality images and services. It is medical, technical, or managerial in nature. It identifies, monitors, and resolves problems. Monitoring problems involves several steps, including establishing criteria, performing monitoring, and collecting, analyzing, and evaluating data. It is these steps of the monitoring process that are of greatest concern to the quality assurance radiographer. Quality control is the aspect of quality assurance that monitors technical equipment to maintain quality standards. It is intended to ensure that equipment performance is consistent with industry benchmarks. It is an ongoing process that crosses many areas of equipment operation and functionality. Purchasing equipment requires the identification of imaging requirements, the development of equipment specifications, the selection of equipment, the installation and testing of equipment, continuing education, and the long-term monitoring of equipment performance. Selection of equipment requires that one compare bids for a device's ability to meet required specifications and cost. The procurement process involves 1. Identification of imaging requirements. 2. Development of equipment specifications. 3. Selection of equipment. 4. Installation and acceptance. 5. Testing. 6. Continuing education. 7. Monitoring of equipment performance. Continuing education must be an ongoing procedure. It is advisable to include both the quality control and in-service education coordinators in the initial training demonstrations. A good in-service program will include an orientation procedure as well as periodic updates on all complex equipment. Collimator, central ray, and Bucky tray accuracy. Light field and X-ray beam congruence is crucial. A 2% surface-to-image distance error is allowed between the primary beam image and the light field size. The centering mark should be within 1% of the light field central ray. The tests for automatic exposure controls should include 1. Exposure reproducibility. Generators must be capable of repeating exposures accurately. This is ensured by measuring the milliröntgens per milliampere seconds of several different exposures with the same technical factors. Computerized dosimeters provide digital readouts or printouts of milliröntgens per milliampere seconds. Reproducibility should be maintained within plus or minus 5%. 2. Ion chamber sensitivity. Ion chambers are gas-filled radiation detectors used in medical imaging to automatically terminate an X-ray exposure when a sufficient dose has been delivered. They are placed between the patient and the image receptor. Most automatic exposure controls utilize 3 ion chambers and permit activation of various combinations during exposures. It is important to ensure that each ion chamber is equally sensitive by comparing the reproducibility of each chamber individually. 3. Image receptor exposure variation control accuracy. Nearly all AEC units provide controls to decrease and increase image receptor, or IR, exposure by changing the sensitivity of the ion chamber. Consultation of equipment manuals will provide the percentage of change each control is designed to produce. A computerized dosimeter can then be employed to obtain milliroentgens per milliampere second measurements to verify the intensity differences for each control. For response capability. Each AEC has a minimum response capability which varies with manufacturer and model. If the AEC cannot respond at the minimum time, there is no assurance that diagnostic quality images can be produced. Response capability is best evaluated by using a computerized dosimeter readout or printout to determine exposure time for AEC exposures made with a small lucite phantom. 5. Backup timer verification. Occasionally, even the best radiographers will forget to activate the proper tube or AEC when this occurs. Patient radiation protection requires that AEC backup timers be functioning to terminate exposures and protect both patient and tube. Digital radiography detectors. Most digital radiography vendors offer a quality control test tool for the periodic evaluation of their detector systems. The primary quality assurance parameter in these systems is known as detective quantum efficiency, or DQE. DQE measures the ratio of the transfer efficiency of the detector as the signal-to-noise ratio squared going into the system compared to that coming out. The formula is signal-noise ratio squared of the output divided by the signal-noise ration of the input. These values range from 0 to 1, with 1 representing a perfect system. Higher DQE values increase the ability to view small or low-contrast structures and are greatly valued in digital radiography systems. Computed radiography PSP systems require regular erasure of the plates, as well as periodic inspection for cracks and surface markings. Erasure should be performed daily unless all PSPs are used every day. Visual inspection for cracks and surface markings should be performed semi-annually, with any plates creating artifacts removed from use immediately in the interval. Digital imaging display monitors require regular quality assurance to ascertain image quality and to monitor phosphor decay. These factors are sometimes referred to as monitor degradation. Both spatial resolution and brightness must be evaluated on a regular basis. Because each imaging modality has developed quality assurance measures, the primary quality issue for a PACS system is the accuracy of the interface between the specific modality system and the electronic medical record, EMR, in the Hospital Information System, HIS, and Radiology Information System, RIS. Some experts in PACS management recommend that data from any system be held in a storage area, sometimes called the fixed queue or penalty box, until the data can be matched with the modality, HIS, and RIS data or until human intervention resolves the mismatched data. This avoids problems with incomplete patient information being dumped into the PACs, where it adds to unfinished work lists, skews data, and contributes to misfiled patient information. The careful analysis of rejected images has proven a valuable aid in diagnosing the radiographic process. Rejected radiographs are also referred to as repeat, retake, or double-dose studies. Even excellent rejected images studies need to take little time or effort to pinpoint conditions that may be easily corrected. Significant reductions in patient dose, radiographer time, and effort, and resources can be achieved with properly executed rejected image analysis. Digital imaging systems require an innovative rejected image analysis. A rejected image analysis involves retaining all rejected radiographs, regardless of cause, for analysis. Any image outside the acceptance limits should be included. The total rejected image rate is a valuable figure to monitor over long periods of time. It is calculated as a percentage of the total number of images produced during the period of the study. The total image figure can be extracted from institutional data in some cases or can be estimated by multiplying the number of examinations by the average number of images produced per examination. Troubleshooting, locating problems when equipment malfunctions, is a diagnostic process. The same reasoning process that a physician uses to diagnose a disease can be applied to radiographic equipment. Beginning with the symptoms, the radiographer can work step by step through a problem-solving procedure to eliminate possible problems until the source of trouble is isolated.